Yeah.
And then the VA people come over, but we don't typically wait.
Oh.
Hi.
Hey,
Nice
nice
to
to
meet
meet
you.
you.
Nice to meet you.
I'm Dan.
Hi, Dan.
Today's my first day.
Your first day?
First day as an assistant resident. I
Oh.
started a month late, so.
Oh, okay. Where did you do your internship?
Wright State in Dayton, Ohio.
Okay.
Yeah.
Oh, welcome.
Okay.
Andrew.
Hi, Andrew.
Nice to meet you.
What's your last name?
Young?
Okay. And are you at the VA right now?
No.
Oh, you're here.
Yes, I just had to tie some stuff up over there. So.
Where'd you do your internship?
So I did residency in pediatrics before, and then took a year off. Did some urgent care stuff for a while, part time, and had a baby, and I'm back at it.
All right. Cool.
Jack. I did my intern here in Indiana.
Okay.
I'm Carly. I did my intern year at UT Houston in surgery. My name is Vicky. I'm an OMFS resident, rotating with anesthesia for
Oh, okay.
another 10 more weeks. So I started with them in July.
Okay.
You know, it's on the streets.
Well, start hitting this. Seems like I might have.
I don't know the way you said it.
It's traumatizing safe parties involved.
No, Ace.
You have this femur traction device within your scene.
Oh,
I feel like it was a giant bar, and I was like, leaning over like this.
Oh,
Dan.
I had to move them.
Easy airway.
That's all fancy.
Oh, okay.
Then she had a over your shoulder section.
Yeah.
Is it like what?
Yeah.
Okay.
And her scapula was broken too.
And she has doing everything.
Dr. Kadir was like,
Why did you put you on this case?
Oh, that's so cute.
like it's fine. It actually didn't fine.
Wait,
It was a good
why?
learning
Was it
experience.
like crazy?
Yeah,
Oh,
it was like a polytrauma, and she had like a. She was stabilized last night, but then
one
came
of the
back to the
CA
OR
ones was
first and
just had a
ortho stuff.
baby yesterday.
But had like a.
Oh,
she was
really?
like a
I think
femur
that's
fracture,
Yeah, Jack.
and
Well, or
just
no,
had
not
some
Jack.
other
Eric
stuff
might
going on.
come, but he's on.
Was she already
She didn't
in
hit
it?
that hard, but
Oh, really?
she lost a lot of blood.
I'm
And she
not
was
sure.
like,
Yeah,
yeah, she wasn't. She was like literally. I gave her a full stick of phenylephrine within like 30 minutes. So,
It's got a drip in, man. I like this habit.
Okay, let me get started. So hopefully you guys saw the awful PowerPoint where I had to record my voice. And that kind of gave you a little bit of a platform. The goal today is really to try to keep things pretty basic since you guys are still in your CA1 year, and then hopefully we'll do more advanced stuff later. But I have a problem-based learning discussion, and this is a real case that I did. So you've been assigned an add-on at the end of a long day. Jerry is an 88-year-old man who fell inside his home last night and suffered a left hip fracture, or femur fracture. He's going to get a left proximal femoral nail placement. He's allergic to penicillin. His past medical history includes hypertension, but he's not on any antihypertensives anymore, and Alzheimer's dementia. He had an appy in the 70s, but otherwise has had no surgeries. Are you bored, or are you already bored? Oh, yeah, thanks. He's on aspirin, 81 milligrams daily. So when you go to see him, he actually is super demented, like nonverbal for the most part, except for some yelling. He's got the mitts on. I'm sure you guys all have seen the mitts. And he has a daughter with him who's clearly really well informed on his medical conditions and a really reasonable person. So just talking about some basics first, and then we'll actually go over a case. But how is the body composition of this guy different than a 25-year-old?
A lot of decreased muscle mass.
Okay.
And atherosclerotic disease, you have to account for in the OR, so you're going to want to probably not tolerate hypotension as well, and keep his pressures up a little higher.
Okay. So as people age, basically they have a total body loss of collagen, right? Their lungs are not as elastic, their heart is not as elastic, their blood vessels are not as elastic. They typically have more fat and less muscle overall. So those are just things to think about when you're positioning, when you're setting up drug doses. What changes occur in his CNS as he ages?
Your brain volume's going to decrease.
Mm-hmm. So you have global atrophy, and it probably is worse when you have Alzheimer's. What about MAC?
MAC decreases with age.
Yeah, do you remember how much?
Once per decade or something.
You got it.
6% per decade.
After what age?
40.
Yeah, good. So even a 50-year-old is going to have 6% lower MAC than a 40-year-old. Now, MAC is still not a hard and fast number, right? It's the number at which 50% of patients don't move to surgical incision. So that doesn't mean that it's for sure like a hard and fast rule, but you know about where you can keep your anesthetic. What else changes with the CNS?
I mean, he already has Alzheimer's, but they are more prone to postoperative delirium.
Yes, good. And in the old, just even a baseline dementia is pretty common. I had Megan in clinic the other day and we talked about dementia, and especially in smart people, that is harder to detect because they compensate so well. So you always should think about that. If anyone, really you should start thinking about dementia and post-op delirium after age 65 or 70, but as soon as a person gets over 85, you should wonder if they have some little baseline dementia. And also the reaction time is different. So when you think about asking patients questions preoperatively, sometimes it takes them a little bit longer to answer. And that's just the reaction time of the brain. You all have a better reaction time than I do. What about, we kind of talked about musculoskeletal system. What are some other things we can think about when we think about positioning patients in all types of procedures, not just fracture?
Limited range of motion.
Yeah, good.
They've had previous joint surgeries or back surgery.
Mm-hmm.
You get more kyphotic as you get older.
Mm-hmm.
Slumped over.
Sometimes neck mobility is not as good. So instead of just kind of casually asking if they can extend their necks, and then make them sit up and show me how far they can extend it. What else? I can't remember if I said this in the slideshow, but for positioning, if you have like a prostate case or a gyne case or something where they're doing lithotomy, and you have a really elderly patient, I'll sometimes have them position themselves before they go off to sleep. It seems a little awkward, but it helps you know that their hips are going to be the way they need them for joint mobility. And then you also have to think about increased risk for pressure ulcers or pressure sores because of nutritional status and body composition as people age. How about the renal system?
Decrease GFR.
And will that be shown or manifested in the patient's creatinine? Yeah, it will. Because how does does that work?
Nutritional status in general.
Yeah. Yeah, so a little 10-year-old lady with a creatinine of 0.9 might actually have GFR less than 60. And then the lungs, we talked about a little bit, loss of elasticity. Even if a patient has larger lungs because of COPD, they just don't spring back as quickly. We talked about cardiac a little bit. So we talked about atherosclerosis. What other changes do we see?
They just can't tolerate having as high of a heart rate as younger people can. They're more careful with that.
I mean, they've lost elasticity in all their vasculature, so they're going to be more prone to either being hypertensive or hypotensive. You know, they're not going to compensate very well in EMGs then.
Right. Yeah. And what about the stretch of the heart? So will ejection fraction change? Yeah, it's still a normal EF is the same no matter your age, right? It's not like right ventricular systolic pressure where it will increase or decrease with age. RVSV will increase, but EF doesn't decrease. But what does sometimes change is we see that reflected in echoes by people talking about diastolic dysfunction, so inability to relax. And that's that elasticity. So now let's talk a little bit more about the case in general. So I have, this is what you know about a patient, is this little bit here. When I saw the patient, in real life, I talked to the daughter. She had a lot of questions about whether or not we should manage this operatively or not. And he clearly was very, just very demented. So for her, quality of life is what mattered, not quantity. He had previously been at home using a walker, not living independently. I think he was in a memory care unit, but he was independent in terms of just being able to walk by himself. And so she had a lot of questions about how he should be managed and whether they were doing the right thing. So I was there with an ortho intern who basically knew none of the answers, but was completely unwilling to explain that he knew none of the answers, so it was just kind of blowing the daughter off. And so she asked him, how come it's a hinge, we just replace the hip? Is that a better outcome? And he didn't really have an answer for that, but what would you guys say?
That's a much bigger operation to replace the whole hip.
Yes. Yep.
So,
And
I mean, it doesn't, in an 88-year-old who's very demented, both of them, this is like a prolonged procedure from an anesthetic standpoint, don't make sense versus a shorter, potentially less anesthetic, but surgery-wise.
yeah. No, that's a great answer. And the other thing is that there are studies that show that the pinning is actually the best management overall. The replacing the hip doesn't increase the longevity of that hip. Just because you have a nail from your femur fracture doesn't mean you'll need a hip replacement sooner. And a lot of these patients die before they get a hip replacement. And then what about timing of the operation? Well, so after I examined him and I was kind of ready to go, I took a listen to his heart and there was this huge murmur. And here's the medicine consult. Basically, I think 5 people had dropped notes and not one person had commented on murmur. They all said radio rate rhythm, no murmurs. And then I just heard this very loud systolic murmur. It radiated to his axilla. I could even hear it a little bit in his carotid. So what's your first thought with that murmur? Yeah. And so does that matter when it comes to our anesthetic?
Yes.
Yeah. Lots of different reasons why, right? So my first thought was, well, we need to figure out if this is either stenosis or Does it matter if I prolong or if I postpone his surgery to get an echo? What if they couldn't do an echo that day and they needed to wait until tomorrow? Does that impact outcomes? I think it does.
I don't know any studies.
So it actually does. Hip fractures, the reason I did this case is that hip fractures are the quintessential illness of the elderly. That's what old people have happen to them. And the earlier you operate on a hip fracture, the better they do. So when you're on call and you really don't want to operate on this hip fracture at 9 o'clock at night, you want to find some excuse to send them back and optimize them. Unless you really think they could get better and you feel like you're putting them in danger by having them go to sleep or get a spinal cord or surgery, then you should just do it. Just do the surgery, get it over with because they have better outcomes.
And does that go for younger people as well?
It's for fragility fractures. So if a younger person broke their hip because they have osteoporosis, then yes. If they did it in a ski accident, then I don't think there's data for that. And if they did it because they have a metastatic disease and they had a fracture, then I don't think there's data for that either. So it's really been studied in fragility fractures. So what would you guys do if you heard a new murmur? There's no echo. You don't know his functional capacity, but you know he walks with a walker.
Or get an EKG?
Okay.
Let's see, you said it was polysystolic, radiating. I mean, you could get like bilateral upper extremity blood pressures. If you get like a bad aortic dissection or something, can't you have different blood pressures or something?
Yeah, I don't know if the dissection, well, I guess if it includes the aortic valve, it would have a murmur. And you'll have to share those, I only have a few. Yeah, so what's in your differential other than aortic stenosis?
So that.
Okay. You also know he fell and you don't know why. So does that add anything to the differential? Okay, he could have had an MI. What else?
The paradoxical.
And this is very unlikely. Yeah, it's really unlikely.
Could he have like a cardiac tumor, like a
atrial myxoma?
Yeah.
Maybe. If it caused MR with it. For tumor. Yeah, MR. The other thing, this is like really reaching, but if he was super dry and had hokum and fell, he might be able to hear a murmur. But we kind of can assume it's aortic stenosis. I really wanted an echo because I don't know how stenotic he is and he fell. So what are the cardinal signs of critical AS? Syncope. And what did you say?
I said exertional.
Yeah, syncope. Yeah, okay. Syncope. What else? Heart failure, right? So CHF symptoms and chest pain. And he's too demented to tell us he had chest pain. He may have had syncope. We have no idea. He didn't look like he was in fluid heart failure. Like he didn't have edema or anything, but we never know. But I also knew we needed to do the case soon. So I didn't get an echo. I tried to do a bedside echo on him, and this was several years ago before we had a lot of probes and kind of before I was trained on focus. And I couldn't really see anything, but I also didn't have the right probe. So I got Dr. Saris, who's like king of cardiac, and he also couldn't find the small probe and he couldn't see anything. And so we basically just assumed he had critical AS. I still don't know either. We never echoed. But we proceeded to the OR, and this is the best part. The resident intern who kind of sucked. We go into the OR, and it's like, what took so long? And I said, oh, I'm sorry we're late. I heard this huge murmur, and no one had said anything about it. And he's like, well, common things being common, it's probably aortic stenosis. Or he said just aortic stenosis. And I was like, just aortic stenosis, that's all. We'll just proceed. But yeah, we did not kill the patient at least. So, say you had any other guy, I handed out the H&P. Let's pretend his labs are normal. Do you want to do a spinal or a general? First let's pretend he's normal. Spinal or general? In general, for fragility fractures, doesn't matter.
Fragility fracture. But for his dementia, it would be awesome if we did a spinal.
Yeah, that's a great reason, right? A spinal with basically no sedation would be great for him.
I think just early rehab, like getting up, move, like, activity, the spinal would be better as well for him.
Mm-hmm.
I don't know about in the case of fragility fractures.
So there are a bunch of studies looking at spinal versus general for fragility fractures, and basically the European orthopedic surgery consensus is try to do spinals if you can. We think there are better outcomes because a lot of the studies are different and none are fantastic. So their whole thing is try to do a spinal if you can. I always try to do a spinal if I can. I find that patients are in quite a bit of pain, although now they have a pathway where they get blocked in the ER here, and that helps a lot. If you roll a patient onto their fractured hip, it tends to stabilize it, and they tolerate the spinal a lot more than if you roll them the opposite direction. So I try to roll them onto the fractured hip and just pop any quick spinal with them side lying. And just a couple of things to remember with that is, number one, your CSF will not come back as quickly because they're not sitting up, so they don't have the gravity to make it drip out. But it doesn't mean you're not in the space. You just have to give it time and aspirate a little more. And then, that's the biggest thing. You can also consider using an isobaric spinal too, instead of just a hyperbaric spinal. The U.S. orthopedic surgeons, their consensus guidelines is basically like it doesn't matter if you do a spinal or general. But I think that that's because the overall kind of culture in the U.S. is to do what surgeons want and not really to do always what's best for the patient. Like, I think they try, and I'm not saying surgeons don't know what's best for their patient, but they also like there are certain operating conditions, and so I don't know if the consensus guidelines are really based as much on evidence, but I also think I'm a little biased for the spinal. So yeah, I would try to do a spinal on a normal guy. That being said, this guy's labs. So first of all, he has aortic stenosis, so we want to do a spinal and critical IS, but we're going to assume he has it.
No, because you get a sympathectomy below the level of your spinal, so you drop your afterload.
Right, and why is afterload so crucial in aortic stenosis?
Oh gosh, yes. So it shuts the aortic valve. It's not, or no,
It
it's
must be back pressure for the
coronary perfusion.
Right.
I just know we use phenylephrine.
No, that's it. So when you have tight AS, you don't have as much blood flow going to the outside of the valve, right? The aortic part of the valve. And then you need that afterload in order to push the blood back through the coronaries. So that's why you have to sustain afterload. The other really important thing is trying to get them in normal sinus rhythm so they get better. So here are his labs. What stands out to you guys? 1.5. Will you do a spinal with my 1.5? Yeah, I would probably try to do 1.4. What else stands out?
Like he has some thrombocytopenia.
Mm-hmm.
Not too terrible, but
Yeah, so
not ideal.
Other combo with 9 hours.
right. So on OB,
And then anemia, so he's just probably got some bone marrow issues.
yeah, it does look like it, huh? On OB, I'll do a spinal with a platelet count as low as 50. But I don't necessarily want to do that for a hip fracture patient, especially with a high IR too, especially when general is an okay bracket. So those are his labs. Obviously, with all of this, I elected to do a general your anesthesia plan?
Use as little as possible, maybe opiate sparing if you can.
Okay,
Maybe multimodal, so you're not relying too much on any one agent. I would definitely use some dexmedetomidine on him.
okay, because,
For the post-op delirium and as an adjunct to the acids
okay.
to limit the house.
What other, do you guys want any other studies before we go back? Sorry, I should have.
Can we get some liver stuff since his iron is elevated?
No, yeah, I didn't have any. That's a good thought.
You type in screen or anything?
I did. So the only other thing that I really wanted, and I did have, was a CT of his head, just because we knew he fell and he was found down. But anyway, sorry, back to the general. Yes, I like a lot of your ideas for general anesthetic. What else do you guys want to do for plan?
As long induction probably.
Okay.
Reduce your intraop opioid as well as hopefully prevent with his aortic stenosis. Help keep the pressure in his heart. Start cold. Just like reduce kind of the shear stress across the bowel.
You also want pressure to drop out very much. So either use something that would come off really fast to warm the effect of the patient, or give something to just support the blood pressure.
Okay, so like what would you want to give for induction?
No.
Oh yeah, yes, I know.
Yeah, like prophylactic, just something lesser as well.
With propofol?
And you could also throw some ketamine in there. Well, does ketamine worsen post-op delirium?
So good question. We'll talk about ketamine and dexmedetomidine with that.
And I would also probably do an awake Halen.
Good. Yes, absolutely. I agree with that. That's good. So yeah, you can do one of a few things. You can do small amounts of propofol with phenylephrine just right off the bat. He was not considered a full stomach. I mean, you could say he was because of trauma, but he had definitely not eaten for like 14 hours or 18 hours. So I didn't treat him like he needed an RSI. But I just slowly worked in the propofol and gave him phenylephrine pops with it after he had an pain. Would you give him a DAS? If he's screaming on the way to the OR? Yeah, I agree. Anyone older than 65, they should have to really, really convince you that they need a DAS. I sometimes look at it like the little ladies who are on chronic benzos, I'll maybe give it, but only if they really need it. Otherwise, I try to avoid it. So, let's see, we said propofol, I said multimodal, so let's talk about dexmedetomidine and ketamine and your delirium risk. Overall, there are no studies showing that ketamine or dexmedetomidine use will decrease or increase your delirium risk. So dexmedetomidine you would think would help with delirium. It does help with ICU delirium when a patient is intubated, but when it comes to post-operative delirium, there are no studies proving that dexmedetomidine will decrease that. There's one study looking at patients who were taken directly to the ICU after large abdominal surgery and kept on a dexmedetomidine drip, and some of their post-op delirium numbers were a little bit lower, but it still wasn't very conclusive. But the best study we have looking at dexmedetomidine in the operating room when a patient was then extubated and taken to PACU isn't shown to decrease the risk of delirium. Ketamine, we think of that worrying that it will increase the risk of delirium, and the study that they've done looking at this in elderly patients actually shows that it doesn't increase the risk of post-op delirium, but in higher doses, patients do complain of some like hallucinations and bad dreams. And so I think that if you're going to use it, you should use it sparingly. But technically, like a half microcular bolus at injection will not increase your risk. So what are some of the things that do increase your risk?
You talked about benzodiazepines.
Yes. and technically anything that's on the Fears criteria. Have you guys heard of Fears criteria drugs? It's a website showing like all the drugs that can contribute to hospital induced delirium, and it's basically every drug is on there. So I guess just try not to use extra of your drugs that you're going to use anyway. What else?
Volatile anesthetics too, so don't they? I mean, or not so much.
Nope, we can't show the volatile anesthetics too. Now in peds, looking at peds delirium, there is some thought that I think it's DES increases your risk versus SIBO. I think they think because of the quick on and off. I'm pretty sure. I don't think peds anymore, so I can't remember that. But in elderly patients, it's okay to use volatile. Now, that being said, does depth of anesthesia matter?
You want to keep them, yeah, I remember. I had one geriatric patient a couple weeks ago, and my attending literally induced them with like 10 milligrams of propofol. Literally, like, he was just like pushing in slowly. It's pretty interesting. And yeah, I think he talked about. Yeah, you were there. Yeah, we didn't want to go.
Yeah. So, again, none of these are like amazing, mind-blowing studies that fit all the criteria for best studies, but most of the studies have shown that keeping patients between like a FIS of 40 to 60 or I think it's 35 to 55 on the set line decreases the risk compared to keeping someone super low with their BIS, like 25. And I think that's the thing I see most often with our elderly patients is that we over-anesthetize them because everyone's so afraid they're going to have recall. But if you calculate their MAC and realize what MAC aware is, you can keep the SIBO or ISO or even DES really low. And they're probably not going to remember, especially when you think about the fact that MAC is additive. You're going to give some opioid probably, you've given other things that will decrease their MAC. So when in doubt and when you're having pressure problems, try to turn on the gas first. But I like the use of the idea of using a bit of Zercetine on them. And then it's the same with sedation. So if you ended up doing a spinal and decided they needed a little bit of sedation, the less sedation you give, the better the outcomes are for delirium. Again, very small studies, but it's what we have. I try to do, I call it a high symptoms chase anesthesia, where I just reassure them and don't give them sedation, but if they need it, I don't want to make them so anxious that causes the delirium too. What else will increase your risk of post-op delirium?
Drop hypertension.
Good. It's actually a hypo or hypertension, so basically unstable hemodynamics.
And cholinergics.
Okay, yep, they can.
I don't know if I probably wouldn't use Decadron. Eventually, steroid induced.
Steroid induced. Yeah, small dose should be okay, but he doesn't really have much risk for PLD, so we have to really leave it off. What about going back to pre-op? What are his pre-op risk factors for post-op delirium? It's a big one, right? What else? What's the other big one?
Inability, or
Age.
Oh, yeah.
Yeah, so the two biggest ones are current presence of dementia and then age. Again, age greater than 85 is another risk factor group. Immobility, well, dependence on your activities of daily living is a risk factor. Actually having a hip fracture from fragility is considered its own independent risk factor. What other patient-associated risk factors are there?
The urgency of the case matter, like an emergent versus an elective case?
Yes, but mostly because of some sort of acute illness. So whether it's sepsis or fractures, things like that. Yeah.
They have like vision or hearing loss.
Good. Yep.
I think males might be more prone to it. I don't know if it's true.
Not that I know of. No.
They're already on a bunch of medications.
So polypharmacy. Any problem or disruption in their day-night cycles. So for him being on the ground for an unknown period of time, was probably a disruption, or someone who comes from the ICU, or even just a regular hospital floor who hasn't gotten good night's sleep for a while. Alcoholism or other drugs. Poor nutritional status. Lower lower educational level to begin with. Those are all risk factors. And we talked about what we could do intra-op. What about post-op for reducing the risk for post-op delirium? What are some little things we can do? Good. Yep. So if a patient already is showing some confusion in the recovery room, the best thing you can do for them is get a family member or someone they know well to come to the bedside and teach that person to reorient them very, very frequently. So, Jack, you just woke up, you had surgery, you're at the University of Colorado. Jack, you just saying it as soon as they are waking up and talking, you repeat over and over again. But it works better if it's someone they know.
Maybe not unpack you, but familiar objects within reach. If they were to go like the ICU or something, so we know it's human beings.
Okay, yeah. I haven't heard of that one,
Pictures
but
and
I
stuff.
like that. Yeah, kind of a reorientation sort of thing. Yeah. Other stuff.
9-day thing we talked about.
Yeah, 9
curtains
day.
open.
Removing any like blind strains, Foley, stuff like that. Putting in their hearing aids, putting their glasses back on. Also optimizing their pain control. So when we talk about wanting to use opioid sparing, we also don't want to wake them up in effective pain because that can cause delirium. So you're kind of between a rock and a hard place sometimes with these patients because you don't want them to be in pain, but then you also don't want to alert them and have that be the cause of delirium. That's most things. So in this case, we put him to sleep. He stayed pretty stable. We did the technique with very little propofol, lots of phenylephrine, intubated him. He was in AFib during part of the case, but he seemed to tolerate it okay. Let's see, did I have any other questions? Oh, why do I keep talking about post-op delirium? Is it important?
You're just like going through it, like it adds on morbidity and mortality and like average cost of the hospital stay and the hospital stay.
Yes, good, exactly. So it costs way more money, they're in the PACU longer, they're in the hospital longer. They often aren't able to return to their previous residence. And you compound that with a hip fracture, which is a huge 50% of hip fracture patients will not be able to return to their previous status of independence a year out from their hip fracture. So if someone was previously independent, they may end up in an assisted living facility. If they were in an assisted living, they may end up in a nursing home. And that's just what happens with hip fractures. It just starts to decline in a lot of patients. I think, I cannot remember, I used to hear that 50% of them will be dead within a year, but that's not true. That's I think it's like 25% though, do pass away within a year of their hip fracture. So it's important to try to minimize their delirium if they're already having a hip fracture. How do you tell the difference between dementia and delirium?
There's like criteria you go by, but is it like I think there's about 4 categories, but it's like is it acute, is it fluctuating? I forget what the other 2 are, but there's like 4 different categories, and then dementia is like a chronically cognitively poor for them.
Yeah, good. So there are assessments you can do. There's like a CAM. You guys probably have done in ICU. But dementia is, yes, more chronic. Delirium waxes and wanes. It's acute. And then how do we treat it? How do we treat delirium other than reorientation? What if it's really bad and you need drugs? What do you get? how well. So one of the most important things is if you get called by a nurse and you're being told the patient's agitated, go to the bedside and find out if they are agitated or confused, or you need to figure out if they're in pain, if they're anxious, or if they're confused. Because one of the kind of not fatal but bad decisions you can make is you hear someone's agitated, the nurse wants you to give Ativan, and so you say yes over the phone and you give it, only to find out that they're delirious, and you don't want to give benzos to a delirious patient. It will just prolong their delirium and it will not help them. But if they really need something to settle down for their safety, you can help. And then, so you guys will have patients or their families who are worried about post-op cognitive decline. How is that different than delirium?
Is that not reversible?
Okay, so yes, it is theoretically not reversible. It's kind of like a post-op dementia, right? Instead of a delirium. And is it real? Yeah, it's good that you guys are confused because we don't really know. There are some scientists who think that post-op cognitive decline is very real, and some who don't. But what studies are showing, at least most recently, is that it's kind of like a staircase where if you have a patient who's having surgery, their post-op cognitive decline might look like this. And if they didn't have surgery, it would have been like this. But at 6 months, they're at the same point as they would have been either way. So that's kind of what we think.
So can you show us again?
Yeah, it's really great.
So like the stair stepping is what they would have done, or that's the
Yeah, exactly. So if someone already has a little bit of dementia and you give them an anesthetic, they might drastically decrease. But if they didn't have the anesthetic or the surgery, we don't know which one it is. Is it the immune response from the surgery or is it the anesthesia? But it would be a more gradual pattern. 6 months out, they'd be the same. I do feel like patients who have some post-op cognitive decline do kind of go like this and get a little bit better after a while. But we don't have any good studies. I mean, it's just when you talk to patients who describe this phenomenon of like word finding difficulties or problems with administrative tasks, they do feel like they recover after a while. And I will tell you, I had surgery in the fall and I had major word finding problems for a while. And I was like, oh, it's my post-op cognitive decline. And I had a colleague in Vermont that I did a bunch of residency education stuff with, and she had surgery like 2 weeks earlier, and she said the exact same thing. And it's totally anecdotal, but I swear it is something. It was really scary and kind of disappointing. I was like, oh, my brain sucks. But I think I'm mostly back normal now. So 6 months, we're good. But if patients ask about that, it's one way that you can reassure them, because families are often really worried, especially if the patient has had that problem in the past. And then there also aren't studies showing that regional is necessarily better than general for this sort of thing, but it makes sense that it would be, and so I try to offer regional for those patients if I can. I always feel like a spinal and nothing that goes to the brain, or at least very little that goes to the brain is better, but I don't think that we really have great studies to prove that. I think that's all I have. Do you guys have any questions?
I'm worried about a spinal injury because of this critical AS. You get the same thing with just a regional block, or is that more just neuraxial?
The sympathectomy?
Yeah.
Most regional blocks should not cause a sympathectomy. Yeah. Even when we don't do, what are they called? Lumbar plexus blocks? Or is it lumbar plexus? We don't do lumbar plexus blocks anymore. But even those didn't really cause a sympathectomy. Any other questions?
Yeah, thank you. Thank you.
All right, wasn't longer, but like the tackle on that.
Thank you.
You want
Yeah,
the papers back?
if you guys don't want them, you can put them in a pile and I'll reuse them next year. And I won't be offended if you don't.
Scribble. People like to appreciate your scribble. Give them the answers.
Yeah.
Thanks for your faces today.
Are you ready to go?
You're in.
Oh, are you guys still carrying here?
Well, I think just Dan.
Okay.
So
Dan is good for style.
Okay.
Okay. This is like a.
We're testing our cognitive,
Yeah, sounds good. Then I'll take off.
upbringing.
Then I'll take off. I should be there around.
Oh, this is all.
Yeah, this is the whole
So I
part.
think you guys just did something that.
I really nice to like, hey, this is like what did you say? Did you ever I'd be like, yeah, you gotta tell me what you did. It was like a laugh.
It's called periodic medicine.
There you go.
My like, and they're like, sure, very I like
Oh, even better.
the steroid.
Beautiful.
And I'm in the middle of lunch. I'm like 12 minutes into lunch, and Dr. Greg comes in and she's like, "How is your patient? You don't hurt him?" I was like, "He's fine." And she's like, "They're calling for blood in your room." I was like, "What?" And she was like, "Yeah, apparently maybe hit an artery or something, but it went from like less than 100 VBL to 500 VBL by the time I was gone. They went like
What kind of case was it?
it was a hip circulation and a paraplegic. But the thing is, his like hematocrit starting was 14.5. She's like, wasn't it from really right?
Yeah, you're welcome.
Nice meeting you.
Yeah, you too. Finally.
Yeah.
I know, we've like,
2 years.
I know, it's taken a long time.
Yeah.
I missed the
Sheldon this weekend.
the meeting. Where do you work here at the U?
Oh yeah, I totally didn't interrupt. I didn't introduce myself at all. I work here at the U, and I haven't gotten to be with any of you guys this summer because I don't know why. I have been in the pre-op clinic more than usual, and I also was supposed to be scheduled with someone for 2 days, and then I had request cases, and I didn't get to work with anyone. So yeah, I'm like a generalist. I do some OB too, and then at Highlands Ranch for a little bit too, so that's probably why.
Where are you?
Yeah,
We're at the
really.
VA, so.
I figured that
Oh,
was
there's two of them?
stress.
Yeah.
Okay. Are you on pain? Or wait, sorry, no, I'm on pain.
Word.
My bad.
Okay.
No,
Did
now
you
you're
get
good.
stuff together?
Gisela, do you?
Not